Hi, this is Arnava Bhattacharjee. Now I am asking about the patient's case history. First is name. Sir, what's your name? Name is important for documentation and record mention. Patient are comfortable if we call by his name. Age. Sir, what's your age? Younger patient is usually slow healing ability. Older patient needs more care. And sex, patient is male patient. Sex is also important because of for sex appearance is higher priority for women. Males may be more concerned about comfort and function of denture. Occupation. Sir, what's your occupation? Executive in high stress jobs may exhibit bruxism. Public speakers singer may need greater alteration to the palatal sir. Location. Sir, where are you from? Some endemic disorder may be confined to certain localities. Phone number. Sir, what's your phone number? Uh, for recalling the patient, phone number is required for further appointment. Chief complaint. This is the primary reason with which the patient come to take a dental advice. It should be described in patient's own word. History of present illness. Uh, Brief the chief complaint in the medical technologies. Now comes to the medical history. Uh, Cardiovascular disease, diabetic history, dermatological disorder, disease of joint, neurological condition, oral malignancy, epilepsy, and for female patient, menopause is also required.
I am Rangashri. Now I will continue with personal history. In that, first, habits. Sir, do you have any habits like smoking, betel nut, alcohol, or tobacco? Patient gives the history of no such deleterious habits. Pan saving, smoking, chronic alcoholism, many modify the systemic status and evoke concerns regarding hygiene, maintenance, and wear of the denture. Next, diet. Patient has a mixed diet. The diet is used to assess the nutrition and protein intake through the diet. Followed by family history. Patient gives the no relevant history. It is taken to assess the genetic condition running in a family or a history of infection present in their family. Nutritional status. It is important to obtain nutritional history of patient to assess the ability of oral tissues to withstand the stress of denture, which is greater in a well-nourished patients, and dietary counsel is necessary in malnutrition patient. Next comes mental attitude of the patient. Dr. M. House in 1950 classified patients as philosophical patient. They are rational and composed in difficult situation. Exacting patient, they are precise and accurate, making severe demands. Indifferent patients, they may not pay any attention to the instructions. They present a questionable or unfavorable prognosis. Hysterical patient, they are emotional, unstable, excitable, or offensive. By attitude of the patient towards dentist and cooperation to the procedure, we can conclude our patient as philosophical patient. Dental history. In dental history, we ask for primary reason for the loss of the teeth. Here, our patient tells he lost most of the teeth due to the periodontal diseases. There is no history of trauma or caries. Reasons for teeth loss provide insight into their appreciation of the dentistry and contribute to the prognosis of the prosthodontic success. The patient should be questioned regarding the reasons of tooth loss, example periodontal disease, gross caries, trauma. The patient who lost their teeth in accident might be more unhappy about their edentulous state than those who lost the teeth as consequences of the decay from their neglect. Next, we ask for the last tooth to be extracted and the duration of edentulous status. This provides information about the bone resorption pattern, progression, timing of the tooth loss. Large, rapid changes occur in alveolar ridge morphology during the first year of extraction. Here, the patient has been completely edentulous for 5 years. Now we ask for the experience with previous denture, if any, duration of usage, reason of seeking replacement. Our patient tells he's been using previous denture for past 5 years, and the reason for replacement is being told that breakage of the lower denture. During cleaning of the denture, we should ask patient expectation of the processes like for function or comfort or aesthetic. Here our patient expectation of processes is for function, and we also should examine the old processes under certain headings like retention, aesthetics, phonetics, comfort, vertical dimension, and masticatory efficiency. Here our patient tells reduced in retention and reduced in aesthetics due to presence of stains and discoloration on the denture base, and compromised comfort.
Hi, I'm gonna talk about the shape of the face. There are four types of face: square, ovoid, tapering, and round. Now we'll check the facial profile. We have three types of facial profile, which is convex, straight, and concave. Now, when we check the patient, the facial profile is straight. Now we check for the color of the face. So the color of the face can be fair, dark, and whitish. So we do this to match the color of the face to the shade of the teeth which we are selecting. Now when you see the patient has fair colored face. Then comes the examination of lips. So in lips we examine the thickness of the lip, which can be thick, medium, and thin. We now check the thickness of the lip in the patient. We check both the upper and lower lip. And now we are checking for the length of the lip. There are short, long, and medium lengths of the lips. In this particular patient, when we check for the length of the lip happens to be medium. Vermilion border, will check whether the vermilion border is visible or not in the patient. Now we'll check for the mentolabial fold, and also we'll check whether it is prominent or not. We check the nasolabial fold. We'll check whether it is prominent. We do this to know the fullness of the lip and also the competency of the lips. There are three types of competency. In this competent of lips, we have potential competent, competent, and incompetent. In potentially competent, the patient should forcefully close the mouth, and if it is competent, the patient when he closes the mouth, the lips are attached to each other. And incompetent, when the patient closes the mouth, there will be a gap between both upper and lower lip, and they do not normally touch each other. Now we check for the tonicity of the muscle. Now we'll ask the patient to do the lateral movements to check for the tonicity of the muscle. And if the patient do the lateral movement, it is indication for the tonicity of muscle. And if the lateral movement is not presented by the patient, then the tonicity of the muscle is lost in that particular patient. Then comes the TMJ examination. There are two types of examination: intra-auricular and pre-tragus examination. So the reason we do TMJ examination is to check whether there is any abnormalities of the TMJ, to check for any tenderness, deviation, or clicking sound. Starting with TMJ examination, we'll stand behind the patient to check for the deviation. So we'll ask the patient to open and close the mouth several times to check for any deviation any clicking sound, etc. So when we examine this patient, there was no any deviation or clicking sound. And the examination which we did was the pretracheal examination. Now we do the intra-auricular examination. So we place our little finger in the tragus part of the ear and ask the patient to open and close the mouth times. Patient there is no clicking sound or deviation or tenderness observed. So now we are going to see deviation and deflection of the jaw. Now we will ask the patient to open and close the mouth, and while closing, if there is any midline shift, and after that midline shift, if it come back to its original position, the deviation experienced by the patient, and if it is completely deflecting towards one side, it is called flexion. Now we ask the patient to open and close the mouth. As you observed, there is no deviation or deflection seen in this patient. So these are the extraoral examination we take up during the case history recording.
Check for residual ridge examination. Under residual ridge examination, we'll check for size of the residual ridge. It may be large, medium or small. Maxillary ridge is large. Even the mandibular ridge is large in this case. Now we'll check for the shape of the residual ridge for both maxilla and mandible. It may be square shaped, U shaped or V shaped. In this case, it is U shaped arch. Even mandible, it is U shaped arch. Now we'll check for the form of the ridge. It may be high well rounded, low well rounded, flat, flabby or knife edge. In this case, maxilla, it is high well rounded ridge. Even the mandible, it is high well rounded ridge. It helps in retention of the denture. Now we'll check for the depth of the hard palate. It may be of three types: medium and normal, flat and wide, narrow and high. In this case, it is medium and normal. Now we'll check for the angular relationship of hard and soft palate. It might be of class 1, class 2, class 3. Class 1 soft palate is horizontal to the hard palate. Class 2 soft palate turns downwards at about 45 degrees to hard palate. Class 3 soft palate turns downwards sharply at about 70 degrees to the hard palate. Now we check for the ridge parallelism, whether it is parallel bilaterally, not parallel bilaterally or parallel unilaterally. In this case, the ridges are parallel bilaterally. Non-parallel ridges will cause movement of bases when teeth occlude because of unfavorable direction of forces. Now we check for the interarch space. In this case, it is adequate. Now coming to arch relationship, we check whether it is orthognathic, prognathic or retrognathic. Orthognathic will have straight arch, prognathic will have protruded arch, retrognathic will have retruded arch. In this case, it is orthognathic. Now we check for the undercuts of both maxilla and mandible. Undercuts also help in retention of the denture.
I will be continuing with Torei. Torre is defined as the bony enlargement or a smooth, rounded anatomical protuberance. It is most commonly seen in the mid-palatine area in the maxillary arch and most commonly in the bilateral in the premolar region of the mandibular arch. In this patient, there is no abnormality detected in this patient. And Torre can be classified as class 1, absent or so small size that will not interference with the denture construction. Class 2, ridges have a torre that offer mild difficulties for the adaptation of the dentures. Surgical interventions is optional. Class 3, torrei are excessively large and prevent undercuts or extends to the PPS. Surgical intervention is needed. The first picture shows the mid-palatine torre and the second picture shows the mandibular lingual side bilateral torre. Next, we are going to talk about the mylohyoid ridge. Mylohyoid ridge is an irregular bony crest extending from the third molar to the lower border of the mandible in the region of the chin. In this patient, it is very prominent. Next is geniotubercle. It is a bony tubercle found anteriorly on labial side of body of mandible. It is prominent in this patient. And next we are going to talk about the lateral throat form. Basically, lateral throat form is classified as class 1, class 2 and class 3. Class 1, approximately 0.5 inch of the space exists between the mylohyoid ridge and floor of the mouth. This is favorable for the lower denture. Class 2, greater than 0.5 inch space exists between the mylohyoid ridge and the floor of the mouth, less favorable prognosis than the class 1. And the class 3, mylohyoid fold is at the level at the mylohyoid ridge. Retention of the lower denture is almost impossible. Next, we are going to talk about the frenal attachment. Frenal is a connecting fold of membrane saving to the support part. Frenal attachment can be classified as class 1. Frenal attachment is known as hyaline maxilla low in mandible. Frenal attachment is closer to the vestibule. Favorable prognosis. Class 2. Frenal attachment is midway between the sulcus and crest of the ridge. Denture border may be notched to allow space. The notch is long U-shape for maxillolabial phoneme and V for the buccal, B for the buccal phoneme. And next is class 3. Freni encroaches the ridge crest. Large notches are needed to allow space for them. Denture seal is difficult to obtain and compromise retention. Surgical correction is needed in this condition. Next, we are going to talk about the mucous membrane. The mucous membrane thickness. Alveolar mucosa is the mucosal covering of the alveolar process. It should be firmly attached to the underneath bone and resilient for good support to the denture. House classification. Class 1, normal mucosa thickness and uniform density of a mucosa is approximately 1 mm thickness is present. The investing membrane is firm but not tense. It forms the ideal cushion for the basal seat of the denture. Class 2, thin mucosa, soft tissue with the thin investing membrane and highly susceptible to irritation. Thick mucosa, soft tissue with mucosa membrane twice the normal thickness. Investing membrane is still firm. The denture have tendency to shift extensively. Next is class 3, soft tissue with thick investing membrane filled with the redundant tissues. This class requires tissue treatment and surgical correction. If not corrected surgically, denture will remove excessively and cause soreness. Clinical application to check the mucosa thickness can be examined with the ball burnisher or T burnisher, where there are area of both thickness and thin mucosa in same arch. It is impossible to equalize the pressure under the denture and avoid soreness. Next, we will talk about the mucosal condition. The alveolar mucosa should be healthy, free of any signs of inflammation, firmly attached and keratinized for providing good support to the complete denture. Mucosa condition can be classified as healthy, coral pink color mucosa, irritated, signs of inflammation present. This may be due to ill-fitting danger and smoking infection or systemic diseases. Pathologic white patches or any other lesion may be present. Most common lesions are found on the edentulous patient or pseudoepitheliomatous hyperplasia, papillary hyperplasia, aphthous ulcer, lichen planus, hyperkeratosis, leukoplakia, etc. The flabby and hypermobile ridge offers poor support because danger base may shift during function. Next, we will talk about the tongue size and position. Tongue. Tongue is a highly mobile muscular organ that plays a significant role in the complete denture fabrication stability. If the patient has been without teeth for a long time, the tongue can become enlarged powerfully. Tongue size may be normal, macroglossia, large tongue, microglossia, small tongue. Now we are going to classify the tongue size. House classification. Class 1, adequate size to fill but not to overfill the floor of the mouth. Alveolar ridge are exposed in the clinical rest position, so the space is present to place denture. Class 2, tongue slightly overfills the floor of the mouth. And class 3, tongue completely fits the floor of the mouth and covers the alveolar ridge. Problem with the class 3 tongue size. Making impression becomes difficult. Denture stability is difficult to attain. Tongue biting is common after incision. Gothic tracing is difficult. Enlarged tongue may be crowded with by a denture base. Next, we will talk about the tongue position. Right classification. Normal tongue position. The tongue fills the floor of the mouth and is confined by the mandibular teeth. Lateral border of the tongue rests on the occlusal surface of the posterior teeth. Apex rests on the incisal edge of the anterior teeth. Class 1, tongue is in the normal retracted position. Floor of the mouth is pulled downwards and exposed back to the molar area. Lateral borders of the tongue are raised above the occlusal plane. Apex of the tongue is pulled downwards in the floor of the mouth. Next is class 2. Tongue is tense and pulled backward and upward. Floor of the mouth is raised and tense. Lateral border of the tongue rests above the mandibular occlusal plane. Apex of the tongue is pulled back onto the body of the tongue and almost disappears. Next, we are going to talk about the saliva consistency and the flow of the saliva. Saliva, it is an alkaline secretion of water, mucin, protein, salt, and often a starch. The amount and consistency of the saliva in the mouth often affect the denture fabrication. Amount and quantity of the saliva, normal, excess, and inadequate. The retention of the denture becomes difficult in the dry mouth and increase the potential for the soreness. Now, types of saliva: seromucous, serous, and mucus. The serous containing is the best to work with and also for the retention of the denture. Fortunately, this is the most common found. A thick mucus saliva makes denture more difficult to wear. Class 1 normal and class 2 excessive. thin, watery, thick, ropey, and excessive saliva may be causing gagging, complicate impression making, affect denture retention. Thick, ropey saliva tends to accumulate between the tissue and the denture and alter the seal of the denture. And class 3, inadequate, reduces the retentive quantity of the denture and may cause the soreness. Clinical note: saliva can be classified by the examining the floor of the mouth. Class 1, wet floor of the mouth. Class 2, floor of the mouth pulled with saliva. Class 3, dry floor of the mouth examined with the cotton swab.
Hello everyone, I'm Aditi of 4th year BDS. Today I'm going to talk about the radiographic examination. So basically there are two types of radiographs, panoramic and periapical. So both of them are essential for treatment planning. For this patient, since he has already removed all teeth, we will use a panoramic radiograph. So what is the use of these radiographs? First of all, to detect any TMJ disorders, any unerupted tooth, any cysts, any tumor, any retained tooth, or to determine, most importantly, to determine the ridge resorption or any root fragments. So basically, there are three types of bone resorption. It is classified into three. So there is mild, there is moderate, and there is severe. Mild bone resorption is up to 1/3, moderate is 1/3 to 2/3, and severe is more than 2/3. So, in the case of this patient, maxilla shows mild resorption, the mandible shows moderate resorption. So, coming to the treatment plan, there are two phases. First is the mouth preparation, and the second is the prosthodontic treatment. Under the mouth preparation, there are various procedures. This could be tissue conditioning or removal of infection or removal of root stumps, any cysts, tumor, or any oral pathologies. We should first treat that. Under the prosthodontic treatment phase, there are various treatments such as immediate denture, overdenture, single CD. This is according to the patient's health and according to patient's desire and depending on the prognosis in the long run. This is the mandibular ridge. This is the maxi ridge, as you can see. There are three classifications: mild, moderate, severe. In this case, the upper ridge shows mild resorption and the lower ridge shows moderate resorption. Thank you.